Okay, it's 7:30 Central Time, so we will go ahead and begin. First of all, I'd like to thank everybody for attending the inaugural Live Journal Club. We're excited. This is an exciting endeavor. There's going to be some learning pains as we go along, and hopefully we'll gain more interest as time goes along. But we're very excited to have a wonderful moderator and author tonight. Before we proceed, I'm just going to take 2 minutes to introduce and also a couple thank yous. This is a journal club that is supposed to be interactive. That's why we're doing the Zoom application. It's a journal club that we plan right now to do the second Tuesday of every other month. So therefore, the next journal club will be December 11th, and we're deciding on an article now. And when I say we, that's the YAPS committee, the Young Aesthetic Plastic Surgeons Committee. I'm the chair of, and I'd like to thank all those committee members that have put forth time and effort to make this happen. I would also like to thank the ASAP staff as well as the ASJ staff as well that did a lot of work on the back end to make this happen. And in particular, Hunter Alexander, who's kind of the man behind the curtain tonight, who's making it all happen. So I'd like to thank him as well. Tonight we are fortunate enough to have the actual author of the article that was chosen, Transition to Non-Opioid Analgesia Does Not Impair Pain Control After Major Aesthetic Plastic Surgery. We're fortunate to have Dr. Clayton Moliver on the call, so you can we'll be able to ask him direct questions. And Dr. Nahai is the inaugural moderator, and we want to thank both of you for attending the first journal club tonight. This is going to be about 30 minutes. We're going to open it up here shortly to Dr. Nahai first with a 5-minute or so presentation. 5 minutes after that, Dr. Moliver, and then we'll open it up to the rest of the gang for some Q&A. I will close by just saying if anyone has any questions, you can scroll with your mouse down to the bottom and you'll see a little chat. And if you click on that chat, you can then see that you can send anyone a message. Since Dr. Nahai is the moderator, we're just asking you to send him a message. Send it simple, just saying, Dr. Smith has a question. And then that will notify Dr. Nahai that someone has a question, and he will call out to that person, so then you can get on and ask specifically and directly Dr. Moliver a question. So without further ado, I will now hand it over to Dr. Nahai. Dr. Nahai.
Thank you, Dr. Tartini. I will start by thanking the entire group, the Young Aesthetic Plastic Surgeons, for initiating this. I'm going to wait till the end of the evening before I thank Hunter. I'm going to see how everything goes technologically. And I also want to thank Clayton Moliver. He's been very much involved with ASJ. And I thank him personally because when I reviewed his paper and finally accepted it, I started making changes in our practice. And I'm happy to say that now the Emory Aesthetic Center is following the recommendations that you made in your excellent article. Hunter, if you can put my first slide up. We're in the middle of an opioid epidemic, and as you can see, go to the first one, the first one from the CDC that describes the entire opioid epidemic. If you look down here, you see more than 40% of U.S. overdose deaths involve prescription opioids. At the bottom, 91 Americans die from opioid overdose, including prescription drugs. 46 plus deaths involve prescription opioids. And then the last line, people are treated in emergency rooms for not using opioids as prescribed. On the next slide, we look at the data from QuadASF. This was 2001 to 2011, almost 6 million procedures, 108 deaths. And if you go to the next one, you can see, as expected, pulmonary embolus was number one. But look at the beige area, 10, and you can see it clearer on the next slide. The fourth leading cause of death, and this is from certified, accredited ambulatory surgical centers, operated on by board-certified plastic surgeons. Overdose, drug overdose, was the fourth leading cause. And then if we go to the next and immediately to the one after that, the more recent review of the Quad A data, again, no surprise, pulmonary embolus is number one, drug overdose is number four. So we're in the middle of an epidemic. A lot of our patients, a lot of these deaths are overdoses. A lot become habituated to the drugs, having been given some after an operation. I'm not even going to mention nausea and vomiting as a problem related to opioids. We'll come to that in a minute. So with that as background, and again, to tell you that reviewing and accepting this article changed the way we're practicing pain management at the Emory Aesthetic Center, I'd like to invite Dr. Clayton Molliver and have him go through how he started in the fall of 2015 with the idea of doing this research.
Well, Dr. Nahai, thank you very much. I'm honored to be chosen to have this paper presented. We really had no idea the opioid crisis was just, about to blossom and go crazy. Frankly, we often stand on the shoulders of others, and it's a kernel of truth in any cliche. In the summer of 2015, Dr. Norman Rappaport presented at the Texas Society meeting his brief experience at that time. It's since expanded, and then he published an article several months ago in ASJ, sort of a pilot study on this protocol. And I came back from that meeting and I said to my staff, we need to change the way we're doing analgesia and post-op. And so we instituted it pretty soon thereafter and just started running with it. We were quite a ways into it when my nurses started telling me that in post-anesthesia care unit, they were seeing a big change in the patients. And that's when, the light bulb went off and I said, well, we need to write up a paper about this. And fortunately, they were all my patients. And so we had historical controls, and it turned out to be very similar demographics. And the numbers surprised even me more than I expected. I thought we'd see some. But as in any retrospective study, we probably could have asked a few more questions, done some pain scales, that kind of thing. So the other thing I wanted to mention was this is a really neat way of doing things. It's almost like a book club, because how many times have we all been to journal club, and to get to have the author present to ask him questions on the nuances of what was involved is pretty good. And I'm going to be sure and tune into future webinars or these events. So I'll present my paper now as we would in Journal Club, and don't hesitate to chime in and ask questions. I'll try and go a little bit quicker. So transition to non-opioid analgesia does not impair pain control after major aesthetic surgery. No disclosures. The ERAS protocol that Dr. Norman Rappaport wrote about in ASJ is enhanced recovery after surgery. And really, when I look back at that, there's so many different protocols for ERAS. It's more of an umbrella description. And it's early ambulation, it's paying attention to nutrition, a lot of things that we all do. It's counseling your patients well. So I think that's just a good modern surgical pre-op and post-op care. I think the big deal is the multimodal analgesia that really has changed things. So multimodal analgesia versus opioid therapy for acute post-operative pain control. There are so many adverse effects with opioids. We all get phone calls from patients. I have a rash. Well, I've got to stop the antibiotics. Even if you try and parse out if it's really an antibiotic kind of rash, it's often the opioids. There's constipation, which is a big problem. Of course, there's addiction. And frankly, I hear in retrospect, I talking about it when people have discussed the paper with me, many patients say, my brain was fuzzy, but the pain really wasn't taken care of. And we're seeing a big shift. And I apologize, I'm obviously biased, but that was that. So the objective was to determine the efficacy of postoperative pain control using a non-opioid pain regimen versus traditional opioids for all aesthetic plastic surgery. I, like most of you, gave Norco or Tylenol number 3, and then we added on all kinds of other things to manage all the side effects. We did a retrospective chart review from November 2015 through July 2017. And the control was patients between November of 2015 and October of 2016. And then the study group was those from October 16 to July 17. That group was a bit smaller. From that group, we had the opioid group, and then the new group was gabapentin and celecoxib. And I'll describe our protocol for you in just a moment. Breakthrough pain was handled with acetaminophen most times, unless it was very bad. Then we went to narcotics in both groups, higher doses or added on. So there was 536 total patients. 76 were excluded. These were people who had known problems with addiction, alcoholism, allergies, sulfur allergies precludes celecoxib, those kind of things. So 462 patients were included. 275 were in the control or opioid group, and 187 were in the steady group. I will say that let me leave that for the end. Demographics were almost identical, 92.7% female in the control, 92.4% in the study group. Average age was about 39, almost no difference. BMI was almost identical, 24.6 versus 24.4. Comorbidities, ethnicity, very, very equal. Procedures performed. I do a lot of breast work in my practice. That was by and far, that was the number one procedure I did. And even in the control period, I always treated them the same as far as what happened on the table. We instill a mixture of lidocaine and marcaine in the pocket. And we didn't put any local anesthetic in the tissue, although I'll address that later. We do now, and that's made an even bigger difference as another multimodal technique. But there were 166 in the control and 103 in the study group on breast. We had a combined group, both had 37. This is mommy makeovers. Face, 34 versus 24, control versus study. We had a liposuction group, a trunk group, and an extremity group. I can tell you those numbers if you're more interested. In terms of postoperative management, about 187 in the study group, as I mentioned before, and 272 in the control group. All of my breast augmentations are dual plane, partial submuscular, so they all get Flexeril to help with muscle spasms. So that was the same in terms of numbers for the breast group, for each group. Smaller because the study group was a bit smaller. In terms of post-op results in post-operative management, the need for additional prescription drugs, there were six patients that needed additional prescription drugs aside from just Tylenol for breakthrough pain, and 15 that needed it in the control group. That didn't reach statistical significance because the study group was a bit smaller, but it was a very small amount, and of course they weren't getting narcotics. Adverse effects, there was no recorded medication side effects, no constipation, nausea, rash, or pruritus in the study group. My staff parenthetically or anecdotally said there was a big drop-off in phone calls for problems. And I noticed the big drop-offs in the evenings, most notably the rashes, the constipation after 3 or 4 days, that kind of thing. In terms of PACU medications, and this is the area that we saw a big change, Dr. Rappaport uses a Phenergan suppository on induction, after induction of anesthesia. We don't use it. We preload with Zofran, celecoxib, and gabapentin at bedtime, and then 4 hours before surgery, and that's all we use for pain and for antiemetic. So in the PACU, there was a huge drop-off, and it was statistically significant in the use of meperidine. We had 23 patients that we had to treat with meperidine in the study group, 124 in the control group. Zofran didn't reach statistical significance. The use of Zofran, we're pretty liberal with that. When they really are having problems in recovery, we do give promethazine, and that reached statistical significance, even accounting for the difference in the group size, 46 in the control group, 5 in the study group. Use of Phenergan, I feel like, as a suppository or postoperatively really prolongs their stay in recovery, and sometimes they get so lethargic and we have problems waking them up, and I'm sure you've all dealt with that as well. Recovery time, the only one that reached statistical significance was the breast group. That N equals 269. In the combined group, the total number was 74 people combined, and that did not reach statistical significance, nor did the face, liposuction, trunk, or extremity. If you actually look at the numbers, with the exception of face, perhaps, because I think we keep them longer, perhaps because we just want to make real sure we don't have any bleeding there for airway issues. I think they were approaching statistical significance, and had the power been greater, I think all of them would have shown statistical significance, because the difference in time is significant in each one of them, but not statistically significant at p less than 0.001 for the breast group. It's 117 minutes versus 103, whereas many of the others, the disparity was much larger. We just didn't have the power to show it. So I really think it decreases PACU time. Well, it does in all of them, but statistically significant. I think it will prove out with time. And again, I mentioned that the breast ones were the ones that showed statistical significance. Limitations, cost. So Celebrex is costly to some people in their plans. If you go to goodrx.com, you can get a coupon. And then sometimes you can find private pharmacies in your area. We have one private pharmacy in our area where for about $45 to $53, you can get all of your medications. So you can find them. You have to look around a little bit. Otherwise, it can be a bit pricey for the celecoxib. Conclusions. From our perspective, and again, I wish we had tested for pain, but it was a retrospective study. We really didn't know we were going to publish this. The gabapentin and Celebrex combo with a predosing with Zofran is as effective as opioids in pain control. We felt this was true by subjectively, by the number of phone calls we got, the reports from the patient, but also objectively from the numbers we had in the PACU. They needed a lot less pain medicine for rescue pain medicine, a lot less time, a lot less nausea and vomiting in recovery. So those are all things we use. I also mentioned that in the abdominoplasties, we do use Exparel. We use a tap block. We infiltrate subfascially, and we infiltrate around the edges of the wound. And we did that in both groups. So that was controlled for as well. More recently, I've started, we've known about this for years, but, I guess you just move through and you just get a routine. I've gone back to putting local at the end of the cases, some Marcaine, lidocaine mixture, and that's had a dramatic improvement as well in our recovery. And I guess there's one other thing, and that we only use 2 anesthetic providers during that whole time, and they rotate every 2 weeks. And they said that they noticed a big difference intraoperatively, and we didn't go back to the anesthetic record. That probably would have been helpful as well to show. I think they used less fentanyl during the case as they dosed them periodically. So they told me that seemed to be true as well. So decreased rescue analgesia, decreased antiemetic use, decreased PACU time, and decreased overall narcotic use. And really, we haven't looked back. That's our protocol. We do occasionally have phone calls from patients and pharmacists. The pharmacist will tell the patient, or the patient will look through on their sheet that comes from CVS or Walgreens, and they'll call in and say, well, wait a second, we didn't get pain medicine, because they look it up and it doesn't say pain medicine specifically. and we have to deal with that and walk them through. And even though we spend a good amount of time preoperatively telling them it's not the same pain medicine, but it's like Botox originally wasn't for these other things. They get it. You have to coach them a little bit. So that's it. I'm open to questions, and I hope I was presented
Thank you.
well.
Thank you very much. I'm smiling because I remember when we started this, the nurses turned around and said, "What? You're not giving them any pain medicine?" So I'm chuckling on that. We do have at least 3 questions for you. Dr. Rafael Couto has some questions. I'll let him ask you in his own words. Part of the question you may already have touched on with the TAP blocks, but Dr. Couto, go ahead and ask Dr. Modaver your questions, please.
Hello, hi. First of all, great study, and thank you for a great article. I guess my first question is in the results section in the paper. It's mentioned that the patients in both groups underwent a similar mix of aesthetic and reconstructive procedures with comparable procedure times. Were you guys able to stratify each group into aesthetic and reconstructive procedures to determine there was any difference between these 2 patient populations?
Yes, we were. And I actually, about 3 or 4 days ago, went back and looked at that. It was 95%, almost exactly. I think it was 95 and 97%, but just almost exactly aesthetic, and the rest reconstructive. And the results were the same in both groups.
Okay. And yeah, great. And then my second question is, will you guys consider doing a patient satisfaction study using this therapeutic modality?
You know, if you'll look at Dr. Norman Rappaport's study, he did a pretty good job. To me, it was a bit of a pilot study. It was only 20 patients, but they did a pretty good job. They asked their patients about a pain scale and patient satisfaction. It's in the journal. I think it's issue 38, volume 6, I believe. It came out this past October. We might consider doing it as time goes on. But we didn't do a pain scale for the control group, and it would be hard to do. It'd have to be a prospective study comparing the 2 groups. And I'm not going back to opioids, so I'm not sure how I'd do it, but that's a good question. Oh, I wanted to say one other thing. In case anyone's wondering, you can, of course, text or email me or whatever. But our protocol is, it's Celebrex is 200 milligrams BID, and the gabapentin is 300 milligrams TID, and we start that at 400 milligrams of Celebrex and 600 milligrams of gabapentin, so we double the dose 1 hour before bedtime, and then we have them wake up about 4 hours before surgery. And I've heard some people say, oh, they just do it an hour before surgery, but we have them wake up about 4 hours before surgery and take another double dose. So we're trying to get them up to that magical 5 doses. You remember that for the half-lives, et cetera, to get them up to a steady state. So 400 of Celebrex, 600 of gabapentin, hour before bedtime, 4 hours before the procedure. And then we go back to the usual dose of 200 milligrams of Celebrex BID and 300 milligrams of gabapentin TID. We also add Zofran to the nighttime and the 4 a.m. dose as well to start getting that up to level as well.
Future directions. Where are you going with this? It sounds as if you have modified some of the things that you do since you wrote this paper. So tell us where you are with this. You just told us how you're preparing the patients and how you're managing them now. Where are you going with it? Are you happy with the current regime? Are you still working at it?
You know, I love it. I mean, we really haven't modified it in the past couple of years. It's been the same. I think there's more word getting out about the opioid crisis. Patients sort of appreciate it. They will tell you that compared to previous surgeries, they're much more alert. They're in control of their environment. I feel better about, telling people they can drive and not having opioids on board. The only other change is I'm sort of going back to what we used to do and recognizing that most of the pain receptors are at skin level. And, as much as we'd like to believe that the others, may cause pain, we've operated on people and under local and they'll complain of this or that, but it seems like 90% of the pain receptors are at skin level. And the patient, my nurse in recovery would tell me they complained of burning pain, and that was always a problem, and we'd have to treat them for that around the incision. And I've gone back to just injecting them around their incision, right before we put the dressings on, or right when with the last stitch, we inject some local. Now the Exparel we dilute with saline and Marcaine, and we inject subfascial, the tap lock, and around the edges of the wound, so I don't have to do it there. But on the breast surgery, mastopexies, of course, facelifts have some local in there, and particularly the breast cases. Big drop off in pain requirements. They wake up even more comfortable. The other place I'm looking to incorporate this, and we haven't done it, is in some of our med spa activities. I think this same protocol is going to be very interesting to get people to get up to that level for RF treatments and other treatments where we'd like to get that treatment a little bit stronger, but they're just uncomfortable. I think this is going to be ideal to dose those patients with this kind of medication and have them tolerate some of those minimally invasive or non-invasive radio frequency or other minimally invasive treatments that might be a little bit uncomfortable. So that's another area that I'm going to start experimenting with shortly.
Good. Well, we have another question, Dr. Obaid Chaudhry. Would you go ahead and ask your question?
Hi. My question was with regards to people on pain management previously for other issues. Were they included in the study? And if so, did you manage them any differently than anyone else?
I can tell you anecdotally, I'd have to go to my collaborators and ask them to go back and go through the data. I don't remember, I don't know. But I can tell you that recently we have had patients who I remember specifically who said, oh, I already take gabapentin. Gabapentin is the big one, not so much Celebrex. So I explained to them the synergy involved, and those people are usually on much higher doses of gabapentin. So we treat them as well, same protocol. A lot of those people really don't want to go back to narcotics. You get a lot of people who've had problems with narcotics in the past, and they're grateful that they don't have to deal with narcotic issues because they really don't want to go there again. So that's pretty good. I might have also mentioned one other thing. Gabapentin is not inert. I've been trolled a little bit online by people who feel like gabapentin is a horrible drug. And, I try to respond to them, and that's a losing cause with trying to respond to those kinds of people. But there's websites out there, there's Facebook sites out there, there's Twitter handles or accounts about the deleterious and harmful and horrible side effects of COX-2 inhibitors and NSAIDs and gabapentin. So there's some people out there that don't want to do it. And I also understand that with the opioid crisis in certain parts of the country, a lot of people are using gabapentin and it's being abused. So you still have to watch it. I don't know what the abuse potential or why they'd want to use it, but apparently there are people that will abuse gabapentin. So, you have to be a responsible physician and just watch how much you're prescribing. I rarely have to prescribe any of this stuff for more than the one prescription that lasts them about a week, and most of them take it about 4 or 5 days and they're done. Occasionally, I will tell people to double their dose of gabapentin, and that seems to take care of it. Or, of course, the breakthrough Tylenol works wonderfully.
Thank you. We do have a couple of other questions, and before I go to Dr. Whitfield, there's a request, and Clayton, I will double that request. Would you please send your regime, the dosage, to Hunter, who can then distribute it to everyone on this journal club? There's a request that you have the protocol disseminated to the group. And with that request, we'll go we'll go to Dr. Whitfield.
Hi, it's a great presentation. I still do a lot of breast reconstruction and use EXPAREL almost exclusively. And I get people in and out of the hospital with very little narcotic usage now. I will certainly implement and use your regimen to help that. But there's a new drug coming to market called XTX-011. It's not formally named yet, but it's a mixture of bupivacaine and meloxicam. So it was studied in breast patients, outpatient breast surgery specifically, and then some, I want to say foot and ankle cases as well. It's supposed to last 5 days beyond, so 72 hours is usually my cutoff for EXPAREL. They price pointed it so it'll compete with EXPAREL. So that should be a better option for us. For us, you know, the negative effects of anti-inflammatories with bone healing, usually I don't consider them a problem in soft tissue surgery at all. The orthopods have been very slow to use EXPAREL at any level, and you know, anywhere I work, and they complain about getting their patients out of the hospital because of nausea, vomiting, pain, you know, narcotic usage. But I've got some of them to use EXPAREL, but this for us, this should be the next level, and it's supposed to last well beyond 72 hours is what, you know, what we use for EXPAREL. So hopefully in the combination of your regimen, in addition to, you know, a drug like this or using EXPAREL, we can really, really limit our narcotic usage.
By the way, I'm not sure if I mentioned it earlier, our EXPAREL dilution, and you can dilute it, everyone's got their own mixture. We use a 100 cc IV bag or IV medication dosing bag. We put 1 amp of EXPAREL, which is 20 cc's in there, with the 100 cc's of saline, and then we add 20 cc's of 0.5% Marcaine. So we have a total mixture of 140 cc's. I don't find it too dilute. It works fine. I get good control for you know 3 days.
Well, we're right at 32 minutes. I think we were planning for 30. It appears that this has been a very good first journal club. I'd like to thank Chad for thinking of this, bringing this idea to us. Clayton, wonderful presentation and discussion. Thank you. We wish you well tomorrow. You'll have no trouble getting up in time. And Hunter, you did a good job. I don't think we had any glitches. So I'll thank everyone and wish you all a good evening.